A 37-year-old male with 2 children, ages 7 and 10, recently lost his job and his mother is dying of cancer. He presents to his primary care practitioner with complaints of feeling down, insomnia, and loss of interest in activities for the last 3 months. When asked about suicidality, he said he's been feeling increasingly suicidal. The patient is prescribed a tricyclic antidepressant, amitriptyline or Elavil, 75 milligrams PO, to be taken at the hour of sleep, and he's given a 30-day supply by his physician with the intention of treating depression. Here's a brief overview of the pharmacology of tricyclic antidepressants. TCAs are an early generation of antidepressants, and their mechanism of action is to block the reuptake of serotonin and norepinephrine, but due to the early generation, they lack selectivity. The lack of selectivity leads to a wide adverse effect profile, and TCA toxicity can lead to deadly cardiac effects. Patients taking TCA should be closely monitored and educated regarding the signs of TCA toxicity, and patients should be promptly treated if TCA toxicity occurs. Patients should be also taught that the medication will not take effect for about 3 weeks after initiating treatment, and the patient should never abruptly discontinue the treatment. Administering the medication at night can help to reduce the adverse effects.
What are the priority assessments for the patient? Broadly speaking, patient assessments can be broken down into 2 categories, psychiatric and physical. For psychiatric assessments, it's important to discuss the clinical features of what the patient is experiencing. The patient reported feeling increasingly suicidal, but we need to determine what exactly the patient means. Is it standalone ideation with a plan, or even plans that have recently been attempted? This is necessary in determining whether or not the patient should be sent home with an antidepressant or hospitalized for observation and treatment. Next, we can use the DSM-5 criteria to determine whether or not a patient is experiencing a major depressive episode. The patient did report feeling down, changes in sleeping patterns, and loss of interest for the past 3 months, as well as suicidality. The DSM-5 requires endorsement of depressed mood and or loss of interest, also known as anhedonia, for 2 weeks or longer, as well as for the additional following criteria. In addition, the provider can also incorporate clinical ratings that again can be used to confirm a diagnosis of depression and also rule out other mood disorders that present with similar symptomatology. These clinical ratings include, but are not limited to, the Mood Disorder Questionnaire, the Patient Health Questionnaire, the Beck Depression Inventory, the Montgomery-Åsberg Depression Rating Scale, and the Inventory of Depressive Symptomatology. And lastly, if the provider does not have a background in psych, then it might be more suitable to have someone else with a psych background consult on the case. Moving on to physical assessments, you'll want to start by doing a full workup to make sure there are no underlying conditions that could be mimicking the symptoms of a major depressive episode, like weight loss or fatigue. Some examples include anemia, renal impairment, cancer, cardiac illness like heart failure, HIV, or hepatitis. You'll want to discuss the patient's current medications and chronic conditions, current symptoms, past medical and mental health history, family history, as well as any family members' responses to antidepressants, insurance, treatment preferences, safety and side effects, and any relevant black box warnings, which for amitriptyline is increased risk of suicidal thoughts and behavior. This is most likely to occur within the first 2 months of treatment and is more likely in patients 24 years or younger. You'll also want to run some labs, including a BMP, CBC, HCG, which is not applicable for this patient, lipids, and nutrition, as well as complete physical assessment. If the patient's symptoms are due to depression and not due to an underlying condition, then you'll also want a pre-treatment EKG with QT correction, as this medication comes with an increased risk of cardiac toxicity. A follow-up EKG will be completed 3 weeks after starting treatment. It will also be important to check serum drug levels after the patient starts treatment, especially if they're using any substances known to increase plasma TCA levels, like serotonin reuptake inhibitors, cannabis, or some pathomimetics. First, if the patient was thoroughly assessed and is determined to have depression with acute suicidality, then the provider needs to determine if it is safe for the patient to be sent home with amitriptyline or if the patient should be hospitalized for observation. We do not have the relevant details, so for this, we will assume it is okay to send the patient home with medication. Since the medication is being given to the patient, then follow-up visits will need to be scheduled. This will occur once a week for the first 4 weeks, bi-weekly for 4 weeks, and then monthly after that. A major issue with the current plan is that the provider is planning to send the patient home with a month's worth of medication. Given the drug's narrow therapeutic index and increased risk of overdose and death, the patient should not be sent home with more than 2 weeks' worth of medication. A recent study of 12 new generation antidepressants found that escitalopram and sertraline were some of the most effective options. Overall, I would recommend the provider switch the patient to one of these meds, as amitriptyline isn't a first-line treatment option due to its black box warning and side effects including orthostatic hypotension, anticholinergic effects, diaphoresis, sedation, cardiac toxicity, seizures, and hypomania. The provider should discuss plans to continue monitoring drug interactions, side effects, and changes in clinical state at follow-up visits, as well as remind the patient of the expected timeline for symptom alleviation to begin. If possible, discuss this with a family member as well so they can monitor the patient at home. Given what we've covered, I do not think the provider's plans are an appropriate course of action for this patient.
Hopefully, you've developed some concerns regarding the provider's actions in this case. Number one, the nurse should consider if this patient is safe to return home. They've expressed increased suicidality, so if the patient expressed an explicit plan to take their own life or conduct self harm, the nurse should alert the provider immediately to identify inpatient care if inpatient treatment can be located. Second, the 30-day supply of medication should be of concern because we have reasons to believe that the patient has a propensity for self-harm, and TCAs are highly toxic if taken in large doses. Third, because amitriptyline is no longer a first-line medication for depression, there may be medications that present more benefit and less risk to the patient. The nurse should ask the provider why they made this decision. The provider may have decided on TCAs because the patient has an allergy to SSRIs, or maybe they've had a family member that had successful treatment of depression with TCAs. If the nurse notices that the patient is taking any medications that could interact with TCAs, they should alert the provider because of the narrow therapeutic index of TCAs.
During the initial visit, it is important for the nurse to convey acceptance and tolerance of the patient's feelings about his situation. Nurses who do this have better outcomes transitioning their patients from death-oriented positions to life-oriented ones, primarily due to the human-to-human connection. Over the next couple of visits, the nurse should remember to confirm the patient. Confirming the patient includes attending to their basic needs, seeing the patient, having time for the patient, being with the patient, listening to the patient without prejudice, being open to the patient, accepting the patient's feelings, and communicating hope. For resources, as a nurse, I would refer the patient to psychotherapy in combination with the pharmacologic treatment. By doing this, the patient will have a professional work with them on managing their depression. I would also make a call to his spouse so that they can become educated on how to support the patient while at home. I might suggest marital counseling and therapy for the patient's spouse if necessary. I would also put him in contact with a social worker and employment and welfare services to alleviate the financial and health burden of unemployment and to help with reemployment when the patient is ready to do so. And I'd also put the patient in contact with crisis prevention lines because it is important to provide a suicidal patient with access to these lines.
Okay, so some clinical assumptions surrounding depression. Depression is commonly viewed as a distinct disease category with no crossover or gray area, and this crossover area is sometimes the crucial area to which treatment can possibly provide relief. So there has been a recent utilization of tools such as Beck Depression Inventory or Hamilton Rating Scale, which allows for only either the presence or absence of underlying depressive disease or disorder. And so this is a poor clinical view of the disease because this only allows for either the presence or absence of the disease. And so if a patient is experiencing insomnia yet still has a healthy appetite and hasn't lashed out, then each of those symptoms hold varying degrees of relativity in regards to severity of a disorder. And leading psychopathologists have found a problem with this, and symptoms may have greater impact on quality of life, yet won't trigger concern when marked off on these scales. And so this kind of shows that depression should not be treated as a discrete category, but rather a dimension of variable symptoms. Which would allow for individual treatment and will accommodate for individual differences in the disorder among patients. So some potential shortcomings in depression diagnosis. In our case, with our 37-year-old patient, there's a potential for all different factors to contribute to a poor evaluation and therefore lead to ineffective treatment for his condition. So the patient could be struggling elsewhere, such as financial troubles, spousal relationships, children's schooling, or their house status, or whether they're houseless or not. And therefore, it's important for us to determine whether they need to talk about other concerns they may have in other areas of their life. And so additionally, failure to maintain contact with the patient for follow-up care directly leads to poor outcomes in treatment adherence, as could a poorly established relationship with the patient. And as mentioned earlier, a social worker should be involved in their care if possible. This would allow them to evaluate any external forces which may hinder their treatment plan or exacerbate their symptoms. And so some other ways in which our patients' clinical evaluation could potentially mislead the provider include focusing on a diagnosis or end solution. So these are kind of assumptions that pertain to our patient. So it's kind of like depressive symptoms, which include insomnia, poor appetite, or overeating, and many other symptoms. They often cluster, but they are also kind of sometimes ignored or just kind of put off as just depressed, related to depression, versus something else that could be going on. So depression often overlaps with other psychological disorders such as anxiety and PTSD. So it's important to not jump to depression as the sole diagnosis, but also consider other possible mental illnesses. And so it's also essential to note the timeline of the patient's symptoms. So it said around 3 months ago, he stated around 3 months ago, he started noticing some differences. some depressive mood. So it's important to determine whether some of these symptoms may have been present even earlier and may have been overlooked by prior medical staff, and so they may be unrelated to the depression. Also, a lot of patients around this age may be categorized into a term known as midlife crisis, since he is 37. So it's important to distinguish and differentiate that this is a depressive episode versus a midlife crisis. So that's a common assumption, is to say, to rule it off as just being a midlife crisis versus a serious depressive episode.
To honor the patient's autonomy, the patient should be made aware of the choices that are available to them, as well as the nurse's responsibility to act in the best interest of the patient and recognize when they may be unable to make choices on their own. The patient's family members should be included in their treatment to ensure that they have a support system to advocate for the patient if they are unable to act autonomously. In terms of beneficence, the provider should be frequently assessing the status of the patient and the nature of the symptomology to determine what treatment is providing the most benefits to the patient. Beneficence is particularly relevant to the choice of what antidepressant medications is suitable for the patient and making the patient aware that the combination of both pharmaceutical therapy and cognitive behavioral therapy can yield the best outcomes for patients with depression. In terms of non-maleficence, the treatment team must be conscious of the ways that the patient may attempt to harm themselves or others, and they should take steps to remove means or opportunities for harm. The team should limit the patient's access to means of self-harm and ensure that the patient is in an environment where they can be monitored for suicidal ideation and behavior. In terms of fidelity, the patient needs to have a trusting relationship with the treatment team. Without trust, the patient may not share all of the applicable information regarding their thoughts or psychological symptoms, which could limit the treatment options available to the patient. And the treatment team must take active steps to learn and understand the patient and to develop that trust with the patient. And to do so, the patient should be reassured that all of the information that is shared with their provider will remain confidential, and the treatment team must uphold those expectations. In terms of justice, it's important to recognize that there are limited resources available for mental health treatment, which could restrict the patient's access to inpatient acute treatment or connecting with a healthcare provider to provide the patient with the necessary cognitive behavioral therapy required for their treatment. Nurses should advocate for the inclusion of these resources at their institution or recognize their role as advocates at the policy level and help institute change and address these challenges. Now I'd like to apply a few of the tenets of the ANA Code of Ethics to this case. When thinking about the relationship with a patient, you want to treat every patient as an individual and evaluate their specific needs. It's also important to remember that when a patient demonstrates self-injurious or self-destructive behavior, the nurse does not necessarily need to support that behavior to support the patient. You need to promote the health and wellness of the patient overall, so acknowledging those behaviors and providing alternatives is an important role of the nurse. Regarding professional boundaries, it's important to be mindful of your self-disclosure and the professional boundaries that you are obliged to maintain with a patient, especially when talking about things that can be so personally moving, such as suicide or mental health care. The protection of rights and privacy and confidentiality is particularly important because we want the patient to be assured that all of the sensitive information they share with the nurse will remain private, and this may help the patient feel more comfortable disclosing some of the difficult thoughts that they may be experiencing. Regarding acting on questionable practice, the nurse is obligated to acknowledge questionable practice of fellow healthcare workers. We discussed this earlier in the case, but we need to hold the physician accountable for the decisions that they made regarding this case. And it's also important to keep in mind that healthcare is a universal human right, and if there are social determinants or boundaries that a patient experiences to accessing care that they are deserving of, it's important for the nurse to look for alternatives and solutions to those problems.